morning, everybody. Thank you so much for spending the morning with all of us. We really look forward every year to the opportunity to talk to you about all of the work that we're doing, which, needless to say, we couldn't be doing with every patient's involvement, as Dr. Zura and Amy have referred to. So today I'll be talking to you about work that we've been doing over the past several years, looking at how we can remodel the tumor microenvironment, and I'll explain what we mean by that, in order to improve the outcomes for our melanoma patients who are receiving treatment with immunotherapy. These are my research disclosures. And I'm happy to say that the treatment landscape in melanoma has changed drastically. When I was a medical student years ago, we really had nothing to offer our patients, unfortunately, other than chemotherapy. And the long and the short of it is that for most patients with melanoma, chemotherapy really doesn't do very much. And over the past decade or so, we've seen the advent of immunotherapy, which has completely revolutionized how everything is done. And many of you will be familiar with the term immunotherapy. These are drugs that patients receive in the IV with the goal of activating their own immune system to wake up and go and find melanoma cells and get rid of them. So the majority of patients with advanced or stage 4 disease will at some point in their treatment journey see immunotherapy, often with anti-PD-1. That's the target that we see for pembrolizumab or Keytruda and nivolumab or Opdivo. And it used to be that only patients with stage 4 were treated, but now we even use it in patients with stage 3 as a matter of routine in order to reduce the risk of the cancer coming back. We have clinical trials, as Amy had alluded to, looking at the impact of using immunotherapy for patients with high-risk stage 2. However, for our patients with stage 4 disease, we know that only a proportion of them will respond to immunotherapy. And when I say respond, I mean have their tumors shrink. And unfortunately, many patients either don't respond up front, or they will respond up front, and eventually the tumor will outsmart the drug. And we all spend a lot of time asking ourselves questions about why that might be. Why does immunotherapy work in some melanoma patients and not others? Why does immunotherapy stop working in some patients for whom it had initially worked? How can we ensure that more patients are responding to immunotherapy upfront? And in patients who initially yield benefit from these drugs and then stop responding, the tumors start growing again on scans, how can we re-sensitize these tumors so that they can become more likely to respond to immunotherapy? And just to make sure we're all on the same page, you may hear all of us talking about the tumor microenvironment. And what in the world do we mean by that? So the tumor microenvironment, or TME, as you'll see it's abbreviated in our slides, refers to the actual environment of the melanoma, of any tumor, but here we're talking about melanoma, of the melanoma tumor itself. What's going on inside of the tumor and what's going on around the tumor. And that includes the immediately surrounding tissues, blood vessels, immune cells, and all of the tissues that make up all of the cells that make up the supporting tissue matrix. That's what we mean by the tumor microenvironment. And there's a whole lot of crosstalk that goes on between the tumor and its surrounding environment. And these have a great, great impact on whether or not patients are responding to therapy. And it's now pretty well accepted across our oncology and sciences community that differences in the tumor microenvironment between different patients and between different tumors play an absolutely critical role in whether or not patients are responding. And we know also that the microenvironment in a tumor is fundamentally deranged. So if you can see my mouse here, this is an example of a normal tissue. This is a non-cancer containing tissue. You can think of lung, lymph node, liver, whatever you would like. And in a normal tissue, you have plenty of good stuff for immune cells to do their job. They have sugar, it's not too acidic, there's plenty of oxygen, they have fat so they can be well nourished and function. In the tumor, on the other hand, things have completely gone out of whack. The glucose concentrations are low, the pH is acidic, there isn't enough oxygen, and so the immune cells just can't do their job. And so the environment between a normal tissue and a tumor tissue is totally different. And one key thing to understand as we move ahead with this talk is that no two tumors are alike. So this is a cross-section. Many of you may have looked at PET scans or CAT scans with us in the clinic, and I can assure you that these three areas that are lighting up, presumably involved by tumor, if we were to look at them all under the microscope, even though we're looking within one patient, these are all very different. Furthermore, if we look at different tumors between different patients, again, things are very significantly heterogeneous. And so this is a key concept. This is what we mean by tumoral heterogeneity. And over the past several years, we have, with the help of our wonderful research team, Amy and all the rest of her team, spent a lot of time looking at patient biopsies under the microscope. And we have finally figured out a good flow by way of doing this. When we get a biopsy of a tumor or a lymph node, it comes to our labs, and we put a piece of it separate to be able to do very specific stains and look at what that looks like. And then we look at the tumor cells themselves, and we also look at the immune cells that are inside of the tumor that hopefully should, if they're doing what they're supposed to do, be killing tumor. And the long and the short of it is that we found that tumor cells coming from different patients look entirely different. And some tumors make their energy by using up a lot of oxygen. These are what we call by highly oxidative tumors. And other tumors make their energy by depending more on glucose up front, and these are what we call glycolytic tumors. And when we break apart tumor cells, and these are again melanoma tumors, we see a lot of heterogeneity between patients, as I said, and this is what we would have expected to find. And when we look at actual immune cells from these patients, we find very interestingly that whether or not an immune cell is coming from a tumor that's depending on oxidative or glycolytic metabolism has a very profound impact on how that immune cell is functioning. And so, to summarize, tumor cells behave differently in different patients, and the way those tumor cells behaves impacts the function of the immune cells. And we now understand that this is critical to whether or not immunotherapy is going to work. We did a whole lot of different testing in the lab to look at what about the function of the immune cells is deranged. And to summarize, we found that the immune cells coming from the tumors with a lot of metabolic action were less likely to be functional. And we measure function of immune cells by different products that they make and release into the environment. And these are called TNF alpha, interferon gamma, and there are many others. But basically, the immune cells coming from the tumors with very high metabolism are making less of the good stuff that helps them to function as they are supposed to. So having found that tumor cells have very different metabolism, and having found that the function of the T cells is significantly impacted by this, we then asked ourselves what, to my mind, as a physician, is the holy grail of questions: does it impact whether or not patients are actually responding to immunotherapy? And the answer seems to be yes. And these are data that we published late last year. We found that when patients' tumor cells, before they received immunotherapy, had a lot of high oxidative metabolism, they were less likely to respond to immunotherapy, meaning their tumors were less likely to shrink. We also found a significant correlation, between the metabolism of the tumor cells themselves and the overall clinical outcomes of the patient, including the duration of their response. You can see here that a patient whose tumor from their melanoma tumors had high oxidative metabolism, the drug was less likely to work for a longer time. Basically, it stopped working sooner. We also found that patients who had melanoma tumor cells that had high oxidative metabolism were likely to have progression on their scans sooner than patients whose tumor cells did not have high oxidative metabolism. And this also seems to have an impact on survival. Again, I want to stress this was a limited cohort of 19 patients, but these were very novel findings that had not previously been described in the literature. We then asked ourselves, since our hypothesis is that these tumor cells are gobbling up all the oxygen, can we see less oxygen or evidence of more hypoxia meaning low oxygen levels, in patients whose tumors are not responding? That's what we would expect to find. And in fact, that's exactly what we did find. We found that the patients whose tumors were not responding to immunotherapy had evidence of more hypoxia or less oxygen in the tumor itself. And again, we think it's because the tumor cells themselves are basically eating up all of the oxygen and not leaving any there for the immune cells, which they need to function. And so our data overall have suggested to us that it's really the tumor's ability to sequester or utilize up oxygen rather than the tumor's ability to utilize glucose, and taking it away from the T cells or immune cells is one of the many, many things, but certainly one of the things we think that renders melanoma tumors resistant to immunotherapy. And so we asked ourselves, how can we make the microenvironment of the tumor less hostile to immune cells, and so make it more likely that tumors will respond to immunotherapy? Is there a way that we can actually change the dynamics inside of the tumor microenvironment? How can we decrease the oxygen consumption of tumor cells? And there are a whole lot of drugs out there that can do this, but you can take it from me, they're very toxic. So we had to think a little bit outside the box about drugs that have this side effect, if you will, of reducing oxygen consumption by tumor cells. And one of these drugs is metformin, which is a diabetes drug that is very widely used. Now, I want to make the key point here that even though metformin is a diabetes drug, what we think it's doing in tumor cells is it's decreasing the tumor's ability to take up oxygen from the environment, thus leaving it there for the immune cells. And there have been a lot of studies across different kinds of cancer, lung, head and neck, breast, that have shown that actually patients who are taking metformin seem to do better overall. And we never really understood why. This hadn't really been described in melanoma, but we have looked at a series of over 2,000 patients at our institution, and we find that this is also the case in melanoma. And this is actually a manuscript that is now going to be under review at a scientific journal. And so in thinking about how we might modulate the tumor microenvironment to make it less hostile to immune cells, we have a research study. Some of you have participated in this study, where we are treating patients with either pembrolizumab or pembrolizumab and metformin, and we take biopsies up front and at 9 weeks of treatment. And the question we ask ourselves here is the metformin actually, the addition of the metformin, allowing the immune cells to work better? And we do a whole lot of different scientific analyses in the lab to try and answer that question. And this study is open and enrolling. And we hypothesize that combining metformin with the anti-PD-1 immunotherapy like pembrolizumab is actually going to allow the T cells or the immune cells to do their job and be more active and divide more, and thus hopefully kill more cancer cells. So that's for patients who are receiving immunotherapy up front, but a lot of patients who will respond to immunotherapy up front will eventually stop doing so. And so one thing we all think spend a lot of time thinking about is how we can resensitize tumors. For example, Dr. Devar, one of my partners, does this through looking at the microbiome, the different microbes in the gut, and we all have different strategies, and you'll hear from Dr. Luke as well later on. But we've been very focused on the metabolism side of things for a few years now. And so we started off by asking ourselves, what do tumor cells look like, metabolically speaking, when a patient has progressed on immunotherapy? When I say progressed, I mean the scan looks worse. And these are data that we generated over the past couple of months in the lab, looking at the tumor cells themselves at progression, that's over here, pre-treatment. And basically, we find that when patients are progressing on their immunotherapy compared to pre-treatment, they have significantly higher likelihood of the tumor cells themselves being highly oxidatively metabolic. So you can see here pre-treatment in black compared to progression, and there's a whole lot more oxidative metabolism, whereas glycolytic metabolism doesn't seem to change all that much. And this is really very much in line with our initial scientific hypothesis that's been driving all of this work. So based on these data that I've just shown you, which suggest that when tumors stop working, it's because they probably have managed to survive the selective pressure by having high oxidative metabolism, we started to think maybe if we can actually remodel the environment of the blood vessels themselves, that might be one way of overcoming this resistance to immunotherapy. Tumor cells, as they divide and turn into full-on tumors, need to supply themselves and nourish themselves. And so they build new blood vessels, and this process is called angiogenesis. And VEGF is one of the key mediators, arguably the key mediator of angiogenesis. And this is a protein that's expressed, and it is key to the formation of new blood vessels in tumors and non-tumor tissues alike. And this is also data that's we generated in my lab in the past couple of months, looking at the expression of VEGF receptor. And there are different kinds of VEGF receptor, VEGFR1, 2, and 3. And to summarize, we see that VEGF expression is pretty variable across tumors, pre and post-treatment. And so understanding that, we didn't want to target a single VEGF receptor. We wanted to target all of them because the differences in VEGF expression pre and post-treatment are not homogeneous across all patients. And so we've been thinking about how to modulate hypoxia or low oxygen in tumors of patients who have stopped responding to anti-PD-1. This is a concept that's been thought about a lot in melanoma and in a whole lot of different tumors. And the long and the short of it is, in melanoma, at least to date, it's kind of been a bust. And we think that might be because the drugs being used were kind of like nukes to the tumor microenvironment. They were just hitting all of the vessels and killing all of the vessels surrounding the tumor and not letting any oxygen get in there. So kind of making things worse instead of making things better. And so we started to think if there might be a little bit more targeted way of doing this. And there's a medication called axitinib that's used in other kinds of cancer that hits all of the VEGF receptors. And it's approved already, and it's been tested already it's been approved in a different cancer, kidney cancer, but it has been looked at in some kinds of melanoma. It has not yet been looked at in patients with melanoma whose tumor specifically stopped responding to immunotherapy. And so what we have proposed to do is to look at the combination of axitinib with anti-PD-1 immunotherapy. And I'll tell you a little bit more about that in a second. And before we went through the process of trying to get this concept up and running, we first asked ourselves if targeting VEGF itself can improve oxygen tension or oxygen levels in the tumor itself. And the answer is yes. I will show you here that when we use a lower dose of axitinib, you can see less hypoxia. However, when you use a very high dose of axitinib, you are seeing more hypoxia. And that's what I meant earlier when I said it's kind of a nuke when you go in at a very high dose. You kill all of the blood vessels, and so you're actually ending up with less oxygen in the tumor, which is essentially the opposite of what we're trying to do. And so we think a lower dose of these kind of drugs is probably the more logical thing to pursue. Before we do any clinical trial with patients, oftentimes we like to find that there's really robust, what we call preclinical rationale. And so these are experiments that we did in mouse models. These are animals that are treated with different drugs trying to treat melanoma. And we find that when we use axitinib with immunotherapy, it works better than when we use immunotherapy alone or axitinib alone, suggesting that there is some synergy between these two different types of drugs, which is, of course, what we had been hoping to see. And so now I will come to this clinical trial that I had mentioned to you. I actually was working this morning on the budget, which tells us we're quite close to getting it up and running. We already have our protocol fully written, and we have many partners that will be helping us get this done. This is a study that will be specifically for patients whose tumors stopped responding to immunotherapy. And we will treat patients with nivolumab, which is Opdivo or anti-PD-1 immunotherapy, and with axitinib. And we hope that this combination and the addition of the axitinib will resensitize these tumors. And like with all of our studies, patients will have a biopsy up front, and then they'll have a biopsy a few weeks into treatment. And we will look very closely at what the differences are in oxygen levels there, in the different kinds of immune cells in the tumor, in the different functionality of immune cells within the tumor, etc. And we're very eager to get that going because this is certainly, unfortunately, a patient population of need. Once patients progress on immunotherapy, we oftentimes don't have a great option, and that's why it's so critical to push the science forward. And with that, I would like to first and foremost thank all of our patients, without whom obviously we couldn't do any of this work, and for whom we do all of this work. My wonderful partners in our melanoma group, our lab technicians, our lab collaborators, and our entire melanoma and regulatory team. And with that, I thank you, and I'm happy to answer any questions.